Thank you for joining the National Headache Foundation's Diet and Migraine webinar. Tonight we are joined by Dr. Kent Dexter of the Headache Care Center in Springfield, Missouri. Dr. Dexter is board certified in internal medicine and was awarded by the United Council of Neurologic Subspecialties, and he holds a certificate of added qualification through the National Board of Certification in Headache Management. Dr. Dexter, thank you for joining us.
Thank you. Well, what I would like to discuss tonight is diet for migraine and is there a role. I put down is there a role because often at the meetings for migraine that we attend, there's very little emphasis on diet, and it seems to have little importance at the meetings, and yet I find clinically there may be a major role where we can use diet in the treatment of migraine sufferers. So with that said, I'd like to basically go over a few objectives. I want to just real briefly go through what migraine is and the impact it has and why it's important that we try to find better treatment options. We're going to discuss comorbid conditions, and we'll explain what that is. We're going to discuss the migraine threshold and how these comorbid conditions may help target treatment options. And then we're going to finish with what role diet can play with some very general guidelines and then open up to questions and answers. In general, migraine is a major neurological problem. It is the most disabling neurological disorder, and that includes dementia and Parkinson's and a variety of other serious disorders. It's ranked 4th in disabling disease for women worldwide, and it's in the top 20 of all disorders. And yet still with this impact on individuals and society, it goes underdiagnosed, often mislabeled as tension headache or sinus headache, and treated just as another pain syndrome. This is clearly now identified as a neurovascular disorder, and that means it involves the nervous system and the nerves as well as the vascular system and the blood vessels. The trigeminal nerve is the major sensory nerve of the face and head and has been the major focus of migraine research. When this trigeminal nerve is activated by what is perceived as a noxious stimulus or trigger, it results in releasing inflammatory substances which cause the blood vessels to dilate and is eventually perceived as severe pain, often very throbbing. But beyond pain, migraine affects vision, our thinking and cognition, the motility of our stomach and bowels, and usually can provide a variety of very unusual sensations. It truly is a manifestation of a complicated, very different nervous system. When we say different nervous system, we see that people with migraine have a hypervigilant nervous system. Often the bright lights or lights are seeming very bright, the noise and the sound seems louder. Any odor seems more noxious. The skin is more sensitive to heat and cold, and even air blowing on it. And there's significant sensitivity to certain foods as well as abnormalities in bowel motility, and often associated with diarrhea and constipation. So this different nervous system, when it is activated by these stimuli, result in a very violent and inappropriate reaction, historically called brainstorm and what we now call migraine attack. So when we look at this nervous system, we have various ways we can look at it and determine what really makes it different. We now understand there's various genetic factors, and these influence often seemingly levels of chemistry in the brain that we call neurotransmitters, or chemicals released by nerve endings and picked up by another nerve that communicate the nerve impulse and actually allow the nervous system to talk to itself. There's also elevated inflammatory substances in this nervous system that seem to be different. So people with migraine have higher levels of dopamine, which is a neurotransmitter. They may have lower levels of serotonin, which also are lower in certain depression states. They have higher levels of prostaglandins or inflammatory substances. There's differences in magnesium levels, and people with migraine are seen to have lower magnesium, particularly inside the cells. There's actually data that shows that the cell metabolism, or the energy production, is impaired in migraine. And there's also insulin resistance. That means it takes more insulin to metabolize glucose and sugar. And insulin resistance is also what leads often to type 2 diabetes or common diabetes. We can also learn what makes this nervous system different by the company it keeps. That means what other conditions exist with migraine. These are some called comorbid conditions that are conditions or problems that are associated at a greater than coincidental occurrence. There's a great article written by Dr. Gretchen Teachin that analyzed a large population of migraine sufferers with a computer analysis, and it dropped out 3 major groups. I think by looking at these groups, we can get a better handle on how we can guide treatment, and particularly we'll tie in how we can guide dietary treatments. Group 1 was a group that manifested with high blood pressure, abnormal blood lipids, particularly cholesterol and triglycerides, a tendency for diabetes, as well as a tendency for low thyroid function or hypothyroidism. This group had a few more males than the other groups, although still migraine is predominantly a female manifested syndrome. It also, the group seemed to be older as they got into more migraines. Group 2 was manifested by depression, anxiety, and fibromyalgia. This group was driven by the mood more than anything. And Group 3 really didn't fall out in any major constellation. What I would like to focus on for the talk tonight is Group 1 and Group 2 and how we might learn some things that would help us guide treatment. So basically, these comorbid conditions defined in those 3 groups, combined with the inherited hypersensitivity, contribute to the migraine threshold. The migraine threshold basically sets how much of a stimulus is going to trigger a migraine attack. So when a stimulus is sufficient for a given threshold, it activates and culminates into a migraine attack. Graphically, I try to depict this as the individual on the left has a very high threshold. As that individual's interreacting, it may take a lot to bring on a headache. And in some cases, there are very few people that never have a headache. But most individuals, by the time they're 70, have experienced at least one headache in their lifetime that would meet migraine criteria. Whereas the individual on the right has a very low threshold and would be considered a migraineur with very frequent headaches. These thresholds not only vary for individuals, but it also varies within the same individual at time. It's a dynamic, fluid type of threshold pattern. It's in constant interaction between environment and influenced highly by lifestyle. To look at this, how it evolves, is we'll take an individual that has a fairly high threshold. It does have insulin resistance. It seems to be associated with more allergies. We've seen that mood is a factor that can influence the threshold. And it's in constant interaction between a variety of internal and external triggers, including weather, hormone cycle, the amount of stress, how adequate rested the person is, their diet, as well as heat and glare and a variety of other triggers. As this nervous system interacts with the environment and changes over time, the person can develop what was a very high threshold, now a very low threshold. And now they go from occasional migraine headache to more frequent headache or chronic migraine. We call this transformation of the migraine or transformational migraine. So where does diet fit into this? Well, we certainly don't want to ignore food triggers. When people say every time I eat MSG or have a hot dog I get a headache, then obviously these things need to be avoided. But way more than identifying the triggers, I think we have to look at the comorbidities in an attempt to decrease the sensitivity to stimuli that can trigger migraine. So we're going to take this group 1, which was basically high blood pressure, abnormal lipids, which include triglycerides, cholesterol, both good and bad cholesterol, a tendency for diabetes and hypothyroidism, and try to understand how this group changed their threshold. They start out with the common thing that seems to run through that is insulin resistance. If we catch this person very early on in their migraine history, we're going to see that this is a person that will get a headache with prolonged fasting, which is a common complaint with migraine sufferers. They also may have hypoglycemia-like symptoms with prolonged fasting that are relieved by food. As they get older, they may develop more snoring and have increased daytime fatigue, and they tend to gain weight centrally, not in the arms and legs, but in the mid-abdomen. They have a higher instance of esophageal reflux, and they tend to complain about brain fog. When I ask migraine sufferers about brain fog, most of them know exactly what you mean. There's also a family history of diabetes in this group. As this insulin resistance interacts with lifestyle and the environment, it can worsen and become metabolic syndrome. Metabolic syndrome is an inflammatory syndrome. It's associated with heart disease and stroke, and it's manifested by high blood pressure, abnormal blood lipids, central obesity or frank obesity. It's associated with vascular or blood vessel inflammation. It's highly associated with sleep apnea, so we have to be on the alert when we see metabolic syndrome to look for sleep apnea. There's an association between low thyroid or hypothyroidism and insulin resistance and metabolic syndrome. And one study showed that 50% of patients with low thyroid function due to an autoimmune, meaning the body made antibodies to the thyroid, were associated with insulin resistance. There's also an association with fatty liver disease, and interestingly enough, both low thyroid and fatty liver disease has often been associated with celiac or gluten allergy. So we're getting kind of a picture of how maybe there's a common thread that runs through the group 1 migraine constellation of comorbidities. And the major transformation factor is lifestyle, from going from insulin resistance to metabolic syndrome. And this is where we can focus on diet and lifestyle changes. We need to be able to recognize this metabolic syndrome. It's an extremely important syndrome to recognize because it does carry a risk for stroke and heart disease, and I think it is something we can attack with therapeutic options. So what is metabolic syndrome? The diagnosis varies by different groups defining it, but they all share most of these factors. Basically, you need 3 of the following factors to make the diagnosis. You need an increased waist circumference, or in other words, central obesity, and this is 40 inches in men or 35 inches in women. The serum triglycerides need to be greater than 150 or equal to 150, or you need to be on drug treatment for elevated triglycerides. The serum good cholesterol, or the HDL cholesterol, is less than 40 in men and less than 50 in women. Or you need to be on treatment for low good cholesterol. Blood pressure is slightly elevated, and the guidelines depict this as being greater than or equal to 130 over 85. This is somewhat lower than what would be diagnosed as high blood pressure. On the other hand, it is felt not to be in the ideal or normal range. You also can receive a point for this if you're on treatment for blood pressure. And you have a tendency for elevated blood sugar of greater than or equal to 100. So if you have 3 of these, you meet the criteria for metabolic syndrome. So that, if we look at group 1, they have many of these features. They have high blood pressure, they have elevated blood lipids, particularly triglycerides, and low good cholesterol. And they have a tendency for diabetes. They also have associated hypothyroidism or low thyroid disease. And if we look at low thyroid disease, as we said before, this can be related to gluten allergy or gluten sensitivity. So it's important to take a look at how gluten may be playing a role in these different comorbidity groups. Gluten is a wheat protein. It is very allergenic. That means the body looks at this as a noxious protein, and it can cause irritation within the wall of the intestine, which allows this protein to be absorbed before it's fully metabolized into its basic parts or amino acids. By doing so, it can create an inflammatory reaction, and in some cases a frank allergic reaction called celiac disease. There are some studies that show that when you are reacting to gluten and having a chronic, smoldering allergic reaction, that it can stimulate the body then to make antibodies to other things, including thyroid gland or the pancreas. And some studies link gluten allergy to autoimmune thyroid disease and even to autoimmune type 1 diabetes. I think the entire verdict is out on that. Gluten is also, when it involves the intestines, associated with a triad of symptoms. Usually this has been taught to be weight loss, malabsorption, meaning you don't absorb the food properly, and diarrhea. However, more recently we are seeing that up to 70% of women with gluten allergy and sensitivity may not present with any of these GI symptoms and only present with neurological symptoms, predominantly headache, numbness and tingling and peripheral neuropathies, and sometimes balance problems and gait abnormalities. The impact of celiac disease in the past was felt to be very rare. In fact, when I was going to medical school years ago, it was said to be 1 in 10,000 people. It now is approaching 1 in 100 people. There are theories about that in terms of how the wheat protein may have changed, the amount of wheat protein we're being exposed to, etc. But in any rate, the gluten allergy has become a significant major problem. And in the absence of being able to document true allergy, the sensitivity of gluten may be as high as 10%. And the important thing with the sensitivity is that they share many of the complaints of the gluten allergy. Gluten allergy and sensitivity seem to also be associated with a variety of psychological symptoms, including anxiety and depression. So that takes us into looking at the group 2, which have been manifested as depression, anxiety, and fibromyalgia. Again, this group has a higher instance of physical and psychological abuse, and they also have a more refractory headache pattern. So if we take group 2, when they start out, the major driving factor seems to be mood. The person starts out with a fairly high threshold. As they manifest more symptoms of mood changes, we see a cyclical pattern to their headache. This is the patient that often gets diagnosed as cluster migraine. Cluster migraine means that their headaches come in a pattern. They may have headaches around their menstrual cycle. What we mean by around the menstrual cycle is they may start a week ahead of the menses and go all the way through the menses. This is clearly more than what we'd expect with just an estrogen trigger. And often this represents a mood disorder called premenstrual dysphoric syndrome or disorder, or a PMS. And we may see either PMS or PMDD contributing to changing the threshold of headache. So if these patients, instead of having a headache one day at the onset of the menses, may have a week-long of headache or 2 weeks of headache every month with their menses. They may have a month of headache and go a month with no headache. They may have, but it's a cyclical pattern, and it often represents some change in the neurochemistry that's manifested by mood and lowers and changes the threshold. They often have a family or personal history of substance abuse. They grow up often in dysfunctional family because often these mood disorders are inherited, and there's an increased incidence of abuse. As time goes on and they are involved in lifestyle stresses, their mood may become more severe and be more manifest as more severe depression or anxiety, and the threshold changes, becoming very low. These patients often get diagnosed as bipolar or serious mood disorder, and often the treatment of these mood disorders are medications that cause weight gain, increased insulin resistance, and diabetes. These patients often become very resistant to treatment, particularly depending on where they're at in their mood swings and cycles. The interesting thing is that bipolar and mood disorders have also been associated with significant insulin resistance. So if we discuss what mood disorders are in the neurochemistry, they're basically chemical changes in the nervous system. You can't be depressed without affecting the neurochemistry, or rather the neurochemistry determines the mood. People who are depressed have a decreased immune response. They're more susceptible to infections. They're more susceptible to a variety of diseases. So anxiety and depression are neurochemical changes. These are not just feelings in your head. PMS and PMDD, whether it be irritability or depression, they lower the threshold and change the threshold for migraine. So it's more than just a hormonal change. It involves a mood or depression or anxiety that contributes to how this nervous system interreacts. And where we look at diet is there seems to be a common thread throughout these, and that is insulin resistance, and particularly those patients in group 1 comorbidities. We have to consider gluten allergy or sensitivity in those with hypothyroidism, excessive seasonal allergies, type 1 diabetes, or fatty liver, as these have been more associated with celiac disease and gluten sensitivity and allergy. And we have to consider the relationship of mood disorders with insulin resistance and frank metabolic syndrome. So that brings us to the diet for migraine. What's the goal? The goal should be to treat and reverse this insulin resistance and metabolic syndrome in hopes that we reduce or increase the threshold. We want to normalize the vascular inflammation. we want to reverse the effects of gluten allergy or sensitivity, and we want to use a dietary management that can help stabilize mood swings and promote a healthy lifestyle. So what does that? There's a vast amount of data on diets. It's all over the place, however. But there's good evidence that very low carbohydrate diets have been used to reverse insulin resistance, to improve diabetic management, and to even stabilize seizure disorders. These very low carbohydrate diets are called ketogenic diets. The unfortunate thing is that's basically protein and fat, and hardly anybody can stay on that diet long term. However, they have been shown to be, in some cases, neurostabilizing. There's more and more data that's showing that Mediterranean diets, particularly Mediterranean diets, they're using low glycemic load foods. Now, what is a low glycemic load food? Means that foods that have a low glycemic index. The glycemic index means how fast does that food get converted to sugar. It's based, the most common scale that's based on is sugar scale. So if you take table sugar and you weigh out 10 grams of table sugar and you feed it to somebody and you measure how fast it gets into blood sugar and raises the blood sugar and causes an insulin response, we arbitrarily assign that a glycemic index of 100. Then we measure other foods to that, so that if you take a sweet potato or an apple, 10 grams of comparable carbohydrate, may get there a third as fast. So it has a glycemic index of in the 30s. And that's what the glycemic index. If you eat foods that have low glycemic index, they impact the sugar and the insulin less. And there's been data that shows that Mediterranean diets that are actually high in grains and fruits and vegetables and leaner meats and stress the importance of monounsaturated fats can actually reverse and improve insulin resistance, and in some cases reverse endothelial dysfunction. Endothelial dysfunction means the blood cell or the lining cells of the blood vessels called endothelial cells are dysfunctional and inflamed, and this inflammation and dysfunction can be reversed with dietary and lifestyle changes. We also can look at the gluten allergy and screen for gluten allergy, and in those patients with GI symptoms, this may take biopsies of the bowel and small intestine, and we can also measure blood tests for antibodies to gluten and certain other associated proteins. So we'd want to screen for these people, and then we'd want to start a diet that can reverse this, and then we need to follow those inflammatory markers, and we need to follow the lipid panel, particularly the good cholesterol, the bad cholesterol, the triglycerides, the blood sugar, and in some cases the insulin level, to make sure that really what we're doing is working. And I think that what I usually do and what I find helps is I'll start with recommendations, and particularly the difficult patients we see at a tertiary headache center, with a very low carbohydrate diet, often 50 grams or less, not counting fiber. Now, I don't want people just to stay at 50 grams or less by eating anything they want or staying away from carbohydrates and then eating one candy bar a day and say, well, that's my 50 grams of carbohydrate. We really stress that they should eat quite a few of the non-root, non-starchy, low glycemic vegetables and some fruit, and they can still stay around 50 grams with sufficient fiber, and really stress the fact that they should supplement the diet with omega-3 fatty acids, and also make sure that they get the proper fats such as olive oil, and in some cases coconut oil, coconut milk are used. But basically, we're talking about staying with a very low glycemic load to the body. For long-term maintenance, these patients often are migrated towards a Mediterranean diet, which is high in grains and fiber and fruit, and high in the right types of fat and the right types of carbohydrates. And I think a diet that also gives a trial, if they don't have antibodies and known gluten allergy, gives a trial of gluten-free to see if they might be gluten sensitive, because there's no way that we can test for gluten sensitivity other than a trial of gluten-free diet. And in some studies it takes more than a month, but at least a month of a gluten-free diet, and then start adding back to see how sensitive they are. I think the supplementations are important with omega-3 fatty acids, and we do often recommend magnesium supplement, although this is helpful in some and not so much in others. It seems to be benefit. Also, there is a tendency when you go to lower glycemic load foods, or particularly the low carbohydrate diets, of getting constipated, and magnesium can help with that. Now, all these recommendations are assuming that the person has normal kidney function and normal liver function. That is key. If people have kidney failure or poor kidney function or have severe liver disease, these diets have to be modified markedly. So in no way do these recommendations apply to people with kidney disease or liver disease. We also, in dietary recommendations, want to avoid common triggers. In general, I think people are going to do better if they avoid highly processed foods. When you start reading labels on foods and what goes into our body, the chemical list is immense. When we're dealing with a sensitive nervous system that is a highly vigilant nervous system, it's unpredictable how some of these chemicals may be analyzed and how they may interact and be looked at as a noxious stimulus. So basically, the diet should focus on the comorbidities, particularly insulin resistance, hypertension, hyperlipidemia, or high cholesterol, and that we have to realize that the diets have to be tweaked and adjusted to make it fit into a person's lifestyle. It should be not looked at as a diet, but as a lifestyle change. And by doing that, what we hope to do is take a person with chronic migraine and a very low threshold and multiple headaches and reverse some of these comorbid conditions by reversing metabolic syndrome, or at least treating it and managing it, and in some cases markedly improving or reversing early diabetes, eliminating gluten sensitivity and gluten allergy, treating aggressively with diet and lifestyle changes as well as medications, and form a dietary plan and lifestyle plan that, in conjunction with proper medical management, can increase the threshold back to more resistance, so that when they're interacting with this outside environment and internal hormone cycles, that they're going to be more resistant. And that basically is the gist of the talk tonight, and I would like to now, if possible, open it up to questions.
Thank you, Dr. Dexter. Our first question comes from John. Why do some food triggers lead to migraine at one time but not at others? This makes it very hard to identify food triggers. Do you have any suggestions?
Yeah, I think, John, that's an excellent question, and I think it addresses that this threshold is in constant change and flux. So basically, as we said before, depending on where you're at, whether you've had enough sleep, stressed, what the exact conditions are, it may take more than one thing to trigger a migraine. So in the case where a person may have not had enough sleep, or there's a weather front, then that food may trigger migraine, but if everything is stable, if there's no weather system going on, there's no increased stress, you're well rested, then it may take more than just a food trigger to trigger the headache. So I think that nervous system is kind of constantly in flux of how sensitive it is, and that's the point that we wanted to stress with the threshold is in constant fluid state. I hope that answers it somewhat.
Our next question from Jan. How long does one have to be gluten-free to see if it helps chronic migraine?
I'm not sure we know exactly. In the patients that I've seen respond, they've responded fairly quickly within 1 month. In the literature, Dr. Katie wrote an extremely good report and study looking at the literature and gluten sensitivity and gluten allergy in relation to migraine. And in some of those studies, they said it could take up to 6 months. Certainly, it takes at least a month. And in most preventive medicines, we allow at least 2 to 3 months before we say it's not going to work at all. But at least 6 weeks to more. So I'm not sure we know exactly. I think it's going to depend on how sensitive they are. Certainly, if you have a severe gluten allergy, that's probably going to respond very quickly. If you're one that has some mild gluten sensitivity, it may take longer to be more apparent.
Thank you. Our next question is from Christine. Is there any scientific evidence that sugar has a negative impact on migraine? And if so, how does sugar work to increase migraine sensitivity?
Well, sugar definitely has seemingly been looked at. There was a study that was actually, I think in 2005, printed in Headache, that took migraine patients that had symptoms of hypoglycemia or headaches with prolonged fasting, and they put them on a very low sugar diet or eliminated free sugar from their diet. Now, sugar, table sugar, is a combination of basically sucrose, is glucose and fructose. And they also eliminated or reduced fructose, particularly these high fructose corn starches. And what they found was close to 75% of the patients had a 50% reduction in headaches. It was a significant reduction. Now, why that occurs is hard to, I'm not sure we know. There's some data that states that the sugar levels really, the blood sugar levels, the glucose levels, do not necessarily correlate with the headache trigger. It may be more the triglycerides, but when you have a high sugar intake, you also get triglyceride elevation, and you have insulin, increase in insulin levels. So I'm not sure that I can answer that 100%, but I think there's multiple factors involved in multiple hormones that we're looking at in terms of what the mechanism might be, and also what the role of insulin when it goes high, what it does inside the central nervous system, which seems to be almost the opposite of what it's doing outside the nervous system. So the short answer to that, I really can't say for sure.
All right. Our next question is from Michelle. Do you think it's worth it to enroll in an inpatient program to better understand all of these syndromes and sensitivities? Or is it best to be at a headache center that can do all of the testing at once?
Well, I think you should be able to get the data that you need on this pretty much as an outpatient. If you're talking about inside the hospital program, certainly I think that this is something that nutritional guidance and working with a nutritionist to try to fine-tune this diet and the dietary approaches are very helpful. As far as the testing, most of that's going to be blood tests that can be done as an outpatient. And even if a patient needs intestinal biopsies, these are all done as outpatients. So I don't think we need an inpatient so much as an inpatient hospital care. The dedicated headache centers, I think, are trying to focus more on the comorbidities and trying to identify these. But these are all tests that can be done through the primary care office and working with a physician So you wouldn't necessarily need inpatient services to get this.
Our next question is from Luis. Should we attempt to implement this diet in healthy adults as a form of prevention from these chronic diseases?
Should we what now?
Should we attempt to implement this diet, I'm assuming gluten-free, in healthy adults as a form of prevention from these chronic diseases?
Well, I think that, certainly that is being done to some extent. I think when it comes down to the diet recommendations, it ought to be a diet. If you look at the Mediterranean diet per se, and particularly the low glycemic load diets and Mediterranean diets, these diets were actually developed to prevent heart disease. And heart disease is still the #1 killer, or cardiovascular disease in general is the #1 killer in all Americans. So we should promote a diet that's away from sugars and junk foods and processed foods, and we should promote a diet that's going to try to prevent and stabilize abnormal blood lipids and sugar levels and prevent diabetes. So yeah, I think that this type of diet is not only good for migraine, it should be good for heart disease prevention and that, and it should be part of a push to get this type of dietary attitude and program throughout the population. However, doing that is somewhat hard, and politically we're seeing when people try to get their Cokes taken away from them or the schools reduced in sugar, there's a lot of uproar. I think we have the freedom to eat anything we want, but our overall health is going to be affected, and I think that the more we can educate people into healthy lifestyles, the better off we're going to be.
All right, it looks like our next question comes in from Darcy. Is there an official migraine diet published anywhere?
There may be a variety of different migraine diets. I don't know of any one that we would feel is an official diet. I think that there's several people through the years I've heard of diets to treat head trauma and this, but I don't know of any definite official diet. In other words, one that's endorsed by the American Headache Society or International Headache Society. Again, I think they look at triggers. They have general guidelines of avoiding red wine and MSG and nitrates, particularly hot dogs and things like this. But as far as an official diet, I don't believe you could say there is one.
Our next question comes from Kelly. Where would you suggest I start with diet changes when stuck in a chronic migraine pain cycle that is 24/7 with no relief?
So when would you start the diet?
Yes.
Well, I think if you're in a 24/7 pain cycle, and particularly if it's associated with so much nausea and vomiting, you obviously need to try to do more than diet. I think you have to really look at what's the driving forces. As we went through the graphics and on those patients, we could see some of the comorbid conditions, and you have to manage those comorbid conditions often with medication. We have to look at, in people that are in 24/7 headache, often are having what we call rebound headache or medication overuse headache. And so many times they're on multiple medications, and some of these medicines are contributing to the headaches and some of them are helping them. But I think you have to start with really understanding what are the major factors of having a 24/7 headache. Number one, this talk was only towards migraine, so we have to assume that we've already ruled out other headache causes. And in many cases, if someone's in a 24/7 headache, you need to really walk carefully into that situation and make sure there's no other things going on, and then manage the entire patient. So it has to be diet and lifestyle and proper medication, and maybe reducing some medications or exchanging them. But there's no easy answer for someone that's 24/7.
Thank you. Our next question is from John. What role, if any, do medications such as triptans have on this threshold? I've used Imitrex as an abortive since it came out, and I seem to be more susceptible to migraines now.
So they were using Imitrex as an abortive, and now they're more sensitive?
Yes.
Okay. Well, I think, John, in that case, again, there are certain medicines, and triptans are one of the classes of medicine, that if you use triptans regularly, and by regularly more than 10 days a month, over a period of months, you may be prone to develop what we call medication overuse headache or rebound headache. So what that means is the headaches can become more frequent instead of less frequent, and that does alter the threshold. So medication overuse can alter the threshold. There's some data, though, and in some patients, that the frequent use, if they have frequent headaches and they can control them with triptans, the triptans, by reducing the headaches, may actually improve the headache frequency. But I think we always have to be on guard. If your headaches are worsening using triptans, one of two things. One is it may be that you're getting into medication overuse headache by using it more than 10 days a month. Or the second thing, there's an underlying comorbidity or change in your threshold that's occurring that's making you more resistant to the triptans, and either of those could be contributing. So I think you have to analyze the whole picture again. It's not going to be so simple just to say it's the triptans or not.
Our next question is from Claire. She says, if she doesn't fit your symptoms in the comorbidity slides, and none of the recommendations have ever been made to her except to limit her caffeine and drink lots of water, are these recommendations still relevant?
I have had, I had patients exactly like this, and I had one patient that came in, and I thought they might have insulin resistance, but when we got the laboratory tests back, they had no evidence of insulin resistance. I had already recommended that they go on a very low glycemic load diet, and when we get the lab back and it shows no evidence of insulin resistance or metabolic syndrome, I thought, well, that's probably not going to help them. They come back 6 weeks later and said, my goodness, they'd gone from greater than 15 days of headache per month to having no headaches in the past month. I've subsequently followed that patient now for another 6 months, and they continue to do very well. So what it's driven me to is look at what other factors could the diet be doing if we don't see these comorbidities. And we're now looking at the role of insulin in the central nervous system, independent of insulin resistance in the body and the periphery. You can have insulin resistance centrally, and this can be associated with autonomic nervous system dysfunction, which is the hallmark of migraine. So some of these patients will respond to the same recommendations, particularly gluten sensitivity, which there's no way to measure for. If a person gives a trial of gluten sensitivity by a gluten-free diet, they may have significant benefit. So I don't think you have to have all those comorbidities to benefit from the diet. The other thing is, again, we're using, at least I'm trying to use a diet like a modified Mediterranean diet that is not only healthy for migraine, but healthy for heart disease, cancer prevention, a variety of things. It's basically getting away from junk foods, highly processed foods, foods that contribute to insulin resistance. So basically we want a diet that's going to be a very healthy lifestyle. And I think each individual needs to try different things and see. If your headaches are doing great and you're eating anything you want, then there's probably going to be little motivation to change.
Thank you. Our next question. You mentioned data that suggests that changes in wheat may have contributed to increased allergic reactions and migraines. Do you believe this could be due to genetically modified wheat?
I think that there's no genetically modified wheat. So as far as that's available in food right now, certainly some of the hybrid varieties that are more resistant may be a factor, but more so I think it's the amount of wheat that we're exposed to, and in some cases in combinations with other medications causing intestinal inflammation, and then the wheat protein gets absorbed improperly. So I'm not sure we can blame it all on the wheat, but the way the bread's made. I mean, many years ago it would rise very slowly, and there's a fermentation process that goes on that actually helps start the metabolism and the breakdown of the gluten. Whereas the idea now is to make bread so that rise very quickly so you can make more faster, and that may be a factor. So there's various things they're looking into. There's authors that have presented different ideas, but I think that clearly it's a combination of, one, it seems to be getting more common, but two, we're also able to screen for antibody testing that we never used to be able to screen for. So now we're finding it in people that don't have the diarrhea and the weight loss, the malabsorption, and these people have probably been out there forever, but we didn't have a test that really measured it. And so I think it's a combination of being able to recognize it clear, and some in the amount of wheat we're exposed to and the processed foods and flour, as well as the way the food is made, is probably all important.
Our next question is from Michelle. I've been suffering from chronic migraine for over 5 years. I have about 22 to 24 migraine days a month, and the other days there is still a faint pain I can feel. I've tried nearly every diet to see if it would make a difference. I've gone gluten-free, dairy-free, carb-free, vegetarian, and nothing has made a difference. I've kept a food journal, but there's been no correlation to my migraines. It's not only the food I eat, but the time of day, the barometric pressure, and so many variables, as you may know. Sometimes I get a migraine at one time, but not necessarily the next. I know it's a case-by-case basis, but I was just wondering if there's anything else I can do.
Well, I think, yeah, it definitely is a case-by-case basis, and I think that you really, I look at headache as one of the most challenging and complicated syndromes there is, and particularly when you get into chronic migraine and headaches that are near daily. It truly is an interaction between the genetic makeup, the comorbid conditions that are associated or developed with that within that individual, and the result of the entire lifetime experience of that individual as relates to stress, psychological and physical trauma, mood and depression, and you have to really focus on all those and try to, in a multidisciplinary approach, find some gradual ways that you can start backing this process down. It's certainly in the area of chronic migraine is going to include a thorough psychological testing and counseling and biofeedback. It's going to take medications to dampen down the threshold, and I think healthy lifestyle. So diet may not even be recognized in the middle of that until we can sort through some of this. I think a healthy diet is still going to be light years ahead of just eating all kinds of junk food, and if you drank, tons of drinks with artificial sweetener, etc., I think these things would make it worse. So even though the diet isn't curing it or making it go away, I think that a healthy diet is going to put you in a better standing for addressing all these other problems.
Our next question comes from Donna. She's had great results eliminating headaches completely at one point for a few years by using the body ecology diet, and she was headache and asthma free for a few years but couldn't keep up with the diet, and she's admittedly struggling with her headaches again. Do you know if there's any research that's looked at a diet like this?
Right off the cuff, I do not. I'd probably have to research it. Does she know of any? I guess there's no way to get back with her, but I was wondering if there was any particular, when she got off the diet, what foods she started incorporating that weren't in the diet that may be contributing to her headache. I mean, there's always, and then forming a diet that was particularly focused on those.
It looks like the diet was essentially sugar-free, wheat-free, rich in vegetables and cultured ones like sauerkraut and kimchi. And it also encourages the consumption of anti-inflammatory foods like coconut oil and cultured coconut.
Okay. So, I mean, it sounds like the diet was working, but it was just hard to stay with it. Is that what I'm hearing?
Yes, it looks like she just couldn't keep up with it. It looks some things that she was going through.
Yeah, I think that, you know, a lot of what she said there are the same type of things that are promoted in the Mediterranean diets, and I think it would be good to talk to a nutritionist and say, here's what worked, and how can you make it more palatable, and how can I stay close to that but still enjoy a good, good lifestyle. And many times the nutritionists can help them with recipes and just altering the, tweaking here and there that makes something that seems very hard to stay with very easy to stay with. And I think I'd definitely get in with somebody and see how can I stay close to this lifestyle but not quite as rigid.
Let's see, it looks like the last question we can address for the night is John's question. If you test for celiac disease and it's negative, can you still be sensitive to gluten?
Yes. Basically, there's no test that we know of right now for gluten sensitivity. Basically, it is in those individuals that when they go on a gluten-free diet find that they're markedly improved in symptoms, and when they reintroduce gluten, the symptoms come back, whether it be headache or other symptomatology of gluten sensitivity. And also, it's very hard to rule out celiac or gluten allergy. So if a person is eating a minimal amount of gluten anyway, and they test for gluten allergy, the antibodies may be negative, and indeed the bile biopsy may be negative because their gluten load is so low that they haven't initiated a severe response. So many times to test for gluten adequately, you have to get a person on fairly high gluten for a month or two and then do the testing to say that the antibodies are negative or there's no evidence of bowel inflammation. So sometimes the tests are done in a state where they're false negative. But even saying that, if all the tests are done totally appropriately, there's still a chance that you can be gluten sensitive up to 10% of the population and will improve how you feel with a gluten-free diet.
All right, it looks like we're about out of time here. I'd like to thank you again, Dr. Dexter, for joining us, and for everyone who tuned in. Stay tuned for our next webinar.